So I'm available for questions now, David.
It looks like we got a few people that jumped in after you start. So let me just repeat my comments at the start. For those of you who don't know me, I'm David Rawson, president and founder of this academy. Welcome me to, I believe I misquoted, it's webinar number 5, I think. We just heard Dr. John Viviano of Toronto give us an excellent talk on CPAP or oral appliances. There are some questions that have already been sent in. I'll read them out. Number 1, are you ready, John?
I am, yes.
Okay, what bite registration method do you use? And what are your thoughts on the phonetic bite registration method? And so I'll start with that one. I've got 2 others in queue here. Okay.
Okay. So, I mean, I'm usual and customary using one of the gauges to advance the jaw in a very conservative manner, because some people don't need a lot of advancement. So I start off with very little advancement and go forward from there. I use the vertical that is based on Lewandowski's work. You know, basically with somebody that's more obese with a bigger tongue, you know, could benefit from having a more vertical, you know, to create more space in there for all that gear that's in, you know, stuffed in there. And so a petite lady would have a smaller vertical, a medium-sized person would have, you know, and so I would range from being minimalist, like around 3 millimeter interincisally, to all the way up to 9, you know, interincisally. And so because a lot of appliances don't allow you to change vertical so easily afterwards, I like to just sort of select that phenotype up front and build it into whichever appliance. And then of course you take into consideration how much vertical that particular appliance you're going to be making needs if there's a minimum, right? So that's, you know, over time where I've gravitated to. Obviously not the only way to do it. I mean, I published something a couple of years ago showing that the phonetic bite got a similar result to my usual and customary approach of advancing, you know, using one of the gauges. And, you know, which much to my surprise, because that whole thing started as like a challenge, like, really, you mean it works? You know, so I can say that, yes, you know, apparently everything under the sun seems to work, because if you can count backwards from a certain number and end up with a particular position. And I know, David, I didn't see your recent presentation on the way you do the phonetic bite, but I've seen you speak about it before. You do the phonetic bite, but end up with something that's much more open than what other people do the phonetic bite, and it works also. So clearly, you know, there's all sorts of different approaches. And I think the reason everybody ends up with a good outcome is because we're all working towards eliminating the apnea. If we're checking objectively in the end, does it really matter which way you go, which way you do it, right? It's not really about, you know, the bite technique, or at least at this point, no one's been able to demonstrate that theirs is the best. Everybody says the way they do it is the best, but there's never really been any good validation of that, you know. So that's my answer.
I've never said mine's better than yours, John. Okay, so for those of you listening, I'm going to read the questions that were sent in while Bianca and I were chatting. But clearly, I will continue to read those. But if you want to ask it verbally, we'll let you turn your mic on. But I've got 3 more for you, John. What is the youngest age for CPAP or oral appliance therapy? What is the youngest age for CPAP or oral appliance therapy?
Well, CPAP, I'm not the person that can answer that. Barry might know. Barry, do you want to unmute and let us know what your thoughts on for CPAP? What would be the youngest? Do you know?
Yeah, sure. Unfortunately, with our obese young patients, there is no option now. You can imagine how difficult and how problematic the use of CPAP is on a developing premaxilla, and it's criminal. But when working in an internship residency program at the Children's Hospital in Philadelphia, when our 2- and 3-year-old obese patients came in, it was a matter of life or death for them. And so we would use CPAP. Now, you are aware, of course, in premature births, etc., CPAP is used regularly. So those masks are made for those kids at that small size, but that's
Temporary.
a temporary use and
Yeah.
made to get them through their preemie stage. Unfortunately, with our obese kids, the common therapy was obviously put them right on some sort of weight control and put them on CPAP, and it's sad to say, in several instances, the only thing we could do for them is trach them. So the answer, therefore, it is used in pediatrics, but then there's this gap that occurs because it's certainly not used in the developing child from ages 4 to 17. 4 to 17, I would not, you would not expect to use a CPAP for that age group, and that's where GMO and others came up in Stanford and other places for that therapy to be functional orthodontics and some type of that could include oral appliance therapy, but preferably just oftentimes dealing with functional orthodontics as opposed to the watch and wait concept of otolaryngology, which existed for years.
Thank you, Barry.
Right. So as far as oral appliances go, I personally would never put oral appliances in anyone's mouth that is not fully developed dentition. But I mean, I've 18, 19, 20-year-olds, I've managed with an oral appliance. Not too common, but I have. So that's the answer to oral appliances. The only exposure I've had to children on CPAP has been in papers I've read, and you see the negative effect it has on the development of their face and so forth. So I think the only place you're going to see that is in the settings that Barry is talking about. Even in Toronto, it's not going to be a go-to thing or a common thing.
Okay. Question number 3, sent in by the chat group. What is the role of myofunctional therapy in sleep? What is the role of myofunctional therapy in sleep?
Well, I mean, if you ask me, I'm going to have a certain position on this, and that it is there. It's being demonstrated. There's a good meta-analysis that was published in a journal of dental sleep medicine a couple of years ago. Can't remember if it was 2017 or 18. But it demonstrates, and that's the one that I quoted in my slides. It demonstrates that as an adjunctive therapy, what I mean, it can be very impactful, and actually for children even more so. The issue with it is compliance and sticking to it. It's not my area of expertise, so I know that Andrea really has gotten involved in that and really enjoys that. Is there anything you'd like to chip in on that topic? Because that's probably more your area of expertise than mine. Well, I know it's not mine. Yeah.
Andrea?
So yeah, I find myofunctional therapy very effective with my pediatric population. So I do a lot of functional orthodontics for growing patients. And even with those patients, with my younger patients, with the myofunctional therapy, I have their parents doing the exercises with them. And you just like any type of therapy, if you're doing like physio, if you had like a problem with your leg and you want it to work in a different way, you're going to need to exercise that muscle. So it's the same kind of thing with the muscles of your airway. If we can exercise them and train them to open up the airway and help us breathe. In my practice, I definitely see a difference, but compliance is for sure an issue. Like it's a constant. You have to keep on training. It will go away pretty quickly if you stop.
Yeah. Good. Thank you, Andrea. By any chance, would your sleep physician have been interested in coming tonight?
She might have if I told her about it.
Oh,
I
okay.
was
All right, that's okay. Just a little political, a political punt there. Okay, that's good. Thank you for that. So
I'm a little bit different than John. Like I find that the sleep doctors in my area actually very they're very they're okay to use oral appliance. They're so I don't find the same thing with the doctors that I'm working with.
Well, for those of you who might know what I'm talking about, when you spoke at our last meeting, you were hoping to have her come with you and speak about that relationship.
Yes.
The relationship we're all trying to develop in all cities around the world, around the country. And yours was a perfect example of two young ladies meshing. And that's what I wanted you to present to our audience, but she was otherwise busy and couldn't do it. So yeah. I just wondered if she was aware and came tonight. We might do a whole topic on that.
Try to get her next time.
Well, no, I'm always looking for subjects, but wouldn't it be wonderful to have the two of you come on and as a model say, here's what we've done in Toronto, here's a couple in Calgary, whatever, because that's what we're all striving to do. We all understand the huge wall between us. John has been way ahead of us, and he's alluded to some of the problems he has as a leader in dental sleep medicine. So think about this, and we can talk privately, but I'd love to have a whole session on just sharing your experiences. What's worked, what hasn't worked? How do you reach out? That sort of thing. Do you take them for lunch? Do you send them wine? Take them golfing? Send them masks or whatever.
Andrew, if I can share something, Andrea, I've been making noise about oral appliance therapy in the Toronto area since 1996. So I have so many arrows in my back, when everybody thought this was witchcraft, right? So I've given these people a lot of reason to hate me and not like me and not welcome me. You're kind of sort of, relatively speaking, new to the game that you walked into, like the ground is being sort of cleared for you, right? So it's.
I appreciate it.
I'm joking, but
Okay.
to a certain extent, that's true,
Okay, just to get back on topic. Thanks, Andrea and John. Now, just so you know, folks, I'm reading the last question submitted under chatter. If you want to send more and don't want to ask, I'm happy to do it for you. But after this, we're going to open the mics to anyone who has an open question for John. So last question I see written is, what is the percentage of posterior open bites using oral appliance therapy? And do you feel obligated to treat it? I'll repeat that, John. What is the percentage of posterior open bites using appliances? And do you feel obligated to treat it, and perhaps how?
Okay, well, I absolutely don't feel obligated to treat it. I myself have a posterior open bite. I've worn an appliance for 21 years. You heard me speak for the last hour. I don't think I have a speech impediment, and I speak very comfortably. I've not needed any dentistry as a result, and I have obviously no problem eating, other than maybe eating too much. So it's really been a non-issue, in my personal life, and my teeth are important to me as a dentist, and dentistry has been my life, right? So speaking personally, I don't see any reason to treat it. Now, if you set the expectation that it's an issue to the patient, right, using traditional dentistry, the way we've been taught to train that cusp-fossil relationship is critical. I mean, that type of mentality does more harm than good, for sure, because it's clearly not critical, and it's clearly made up stuff. And so that's one of the things that we've learned as a result of making oral appliances around the world and creating these bite changes, and not have all of the terrible things happen that were supposed to happen as a result. Right. So, I mean, I am very transparent with this with my patients, and I explain to them the potential for bite change. I even show them mine. And once I explain it to them in that fashion, it's really not an issue to them. They want to resolve their problem, and they don't want to wear CPAP. Typically, they're coming to me because they have tried CPAP and can't tolerate wearing it, but they're tired of feeling tired. So they're looking for a solution. So that is never being an issue to them. Now, if it's presented, oh my God, if this happens, and if you put fear in the patient, right? Well, then, you got a problem right up front, and so even making promises that, oh, if I use this particular appliance because it's going to prevent bite changes from taking place, or I recommend using this protocol with an AM aligner and it's going to prevent bite changes from taking place. Well, what I'm going to say to that is you're setting yourself up for failure. You're setting yourself up to have meet an expectation that I'm honestly, I don't think it's possible to meet. The moment, you find a way to beat physics, right? Then maybe you stand a chance of actually fulfilling that expectation, but we can't, right? And patients don't always comply and do, what you're asking them to do anyway. And even if they do, the bite changes can happen. The posterior open bite can happen, teeth can shift. So the bottom line is there's a lot of variables here. And bite changes are a part of wearing oral appliance therapy, and it does not stop people from continuing with wearing the oral appliance. And it only really creates a problem when a dentist has put into the patient's head that it's a problem. Okay, so that's, I think I answered the question. Did I miss anything?
Well, let me just add, John, that I agree with you totally. And usually it's the dentist, the referring dentist, or a dentist who sees your patient who says, oh my God, there's a gap here. The world's coming apart. Who did this? And yeah, so we have a communication problem within our profession as well. But let's just be honest. You haven't posterior open bite, so you can buy thicker steaks, right?
Yeah. The interesting thing, I posted an article on LinkedIn. This was maybe about 5-6 years ago. It's archived. It's there if you look back at my previous posts. And I went in to deliver an upper bicuspid and asked the guy to bite. And he was only touching on his 7s. Didn't have 8s. He was only touching on his 7s. Nothing anterior to the 7s contacted. And I said, no, bite. And I look and I'm saying, geez, how did I prepare this crown, take a bite, because it took like a snap bite impression, right? And I got it made and I'm going to deliver. And that's what I'm realizing, that's his bite, right? And I asked the guy, do you eat steaks? Mm-hmm. And he says, oh yeah. And I mean, the guy had no issues at all with his bite being like that. And he disclosed to me that my bite has always been like that. It's not ever been an issue for him. Right. Yet, as dentists, we see something like that and we think, oh my God, this is terrible. We have to fix this, right? So, it's made up stuff. Now, there is something that I would like, I think you folks need to hear this. We're lucky that she's actually joined us here. Thank you, Dr. Morang, for joining us. If I may, David, I'd like to just introduce Dr. Morang as an ENT. And I spoke to her for the first time just a couple of weeks ago and had a nice conversation on the phone about what she has to offer in the Toronto area. So since these dentists are from the Toronto area, I think it would be great if she just spent a couple of minutes just talking about what she does as a sleep ENT, if that's okay.
Absolutely.
Okay.
Dr. Morang, you have the floor.
Perfect. Thank you, John. Well, first I want to say thank you, John. That was such a good, comprehensive talk. And, I can't agree with you more. The statement you made about oral appliances can either be the full journey or just the starts of it is exactly correct. I'm in the unique position where I'm a sleep physician and an ENT. So I did my fellowship training in Amsterdam, and the model there is completely different from here. It's completely collaborative. And there's a key component that we do, which is called drug-induced sleep endoscopy. So drug-induced sleep endoscopy is where a patient would come to us, either one, because I've just diagnosed them with sleep apnea, or they've been diagnosed with sleep apnea and they're looking for options to the CPAP that they've been prescribed. And what we do is we simulate sleep with sedation, just to the point where a patient's snoring or they have some sleep apnea. And we can look at the different anatomic sites all the way from the palate down to the epiglottis. And I can see that from my experience in doing this, that the majority of patients that we see are either excellent candidates for an oral appliance or combination therapy, where during sleep endoscopy, we do modify jaw thrust maneuvers. We can see the airway open up beautifully at the tongue base, but sometimes in some cases, they may have a little bit of vibration still happening at the palate. So then we can actually counsel those patients to say, you know what, the oral appliance is definitely the way to go for you, because you don't want to have CPAP, or you've tried it and it does not work. But sometimes you may need a combination. It may be an oral appliance with a minimally invasive procedure just to tighten up the palate. But that's pretty much what my practice is about. It is focusing on sleep diagnostics for the patient. Having the sleep endoscopy there, which we believe, starting from my fellowship, and now I'm trying to introduce that here in North America, that sleep endoscopy is an extension of the history and physical exam we do with a patient. You need to have an understanding of the anatomy to be able to properly treat that patient. So I don't think it's correct to tell a patient, yes, you have sleep apnea and here's your prescription for CPAP. You need to have a better approach, because not everyone, as you said perfectly, John, that not everyone can tolerate it. So that's my role here, in that I try to stand as an objective, unbiased, platform for patients to come to me, where I can assess them and basically let them know what their alternatives to CPAP are.
Thank you, Doctor. As a moderator, I've just gotten a question. I'm going to take this out of order because I don't know how long you can stay with us. So this is a question for you. What is the criteria that a patient would need to have to get DICE? And do they need to get referred by a sleep physician, or can be referred by a family doc? So,
or a dentist.
I think she knows that we dentists can't refer directly into the medical
But I'm wondering
system.
for her, I don't know.
Let me repeat the question. So what is the criteria needed for DICE? And do they need to be referred by a sleep doc or a family doc? That's basically it.
Sure. So in terms of the referral, and John and I spoke about this too, where that has been a barrier to collaboration, right? Where you should be, as a dental professional, be able to communicate directly with me, and we should be able to work together with your patients. But then there's that referral process. So in my practice, what I have done now is I've removed that barrier. So anyone pretty much as a dental professional, family doctor, an allied person, or the patient themselves can pretty much go onto my website and contact me for a consultation or call my office, but it's direct. There's no need for a referral for a consultation to see if DICE would be suitable for you. Now, in terms of the criteria for DICE, we have a BMI cutoff just because it's sedation. So we have to make sure the airway safety is the priority, right? So it's a BMI of 35 or less. And then the patient, we look at the anesthesia classifications when it comes to ASA. So a patient has to be either healthy, or if they do have morbidities, it would be, such as hypertension or diabetes, that they're controlled. And those are pretty much that's the main criteria for having DICE done.
Excellent. Thank you very much.
No problem.
If you stand, I see more questions coming in, but I have to get back in line because Wendy, oh, sorry, I wasn't supposed to say that, Wendy. Question for John. What are the contributing factors for a class 3 occlusion to develop after wearing oral appliance therapy? What are the contributing factors for developing a class 3 malocclusion to develop after wearing an MAD? John?
I just waving at Sharon. I haven't seen her in so long. Very Sharon. So what are the
contributing factors for a class 3 malocclusion or class 3 occlusion developing after wearing an oral appliance?
I'm sorry, what are the contributing factors is what you're asking?
What are the contributing factors? Oh, maybe I'm reading this wrong. What are the contributing factors for a class 3 occlusion to develop after wearing it? No, I think the question is, can you develop a class 3 occlusion because of the MAD concept? In other words, the more you go forward.
So look at the forces that what's being described in the literature is the forces on the lower mandibular teeth and bicuspids are to move them forward. The forces on the upper molars and bicuspids are to distalize them. So what are you doing? You're creating a class 3. You're moving towards a class 3, right? That's what the literature shows us. Those studies that have evaluated tooth movement. Markland's done some of that work. So, does that mean that it's going to happen with everyone? No, it happens to varying degrees, right? And we know that there are some people that wear an appliance for 20 years and don't experience any tooth movement. I see that in my patients. I'm sure all of you see it in your patients. You get some people where it seems like almost happening, within the first year they're wearing an appliance, and other people, they're 8 years into wearing an appliance and there's been no bite changes whatsoever, right? So it happens to varying degrees. And, yes, you get changes in the anterior, changes on the buccals, and it's the type of tooth movement. Most of these types of studies have been with push style or compression style appliances, like a dorsal or a Herbst. And so as a result, those are the forces, and that's how it's translating to the teeth, and so it's a part of it. And it's going to be, in my opinion now, determined in part by how far you advance that patient, by their periodontal status and how much bone there is around those teeth, the amount of parafunction that's going to vary from patient to patient. And so, in other words, the amount of forces that are actually being transmitted to the dentition, it's going to vary, So, there's all these different variables, plus I'm sure other things that come together that is going to contribute to the end result. And as a result, we get all these different things happening. We know in general the tendency of the type of movement that takes place, but the degree varies. And so to say you can stop it altogether, or you can prevent it from happening, it's just nonsense, because it's physics. And we don't have control. I'm sorry, Barry, let me just finish. And then the other aspect of it is the jaw anteriorization, because one part is actual physical, movement of the teeth that's being measured and documented, by Markland and others, right? And then the other part is, as the jaw translated forward, is it actually sitting a little bit further forward than it was before? So you got a combination of these two things that happen to varying degrees. Yes, Barry, that's all I wanted to add. Yeah.
The bottom line is what the question is, what are the risk factors? And the answer is we don't have any. So there is no evidence. We can't look at a particular case and suggest that it's more likely to wind up in a class 3, whether it's a specific appliance or a specific starting occlusion. What we do know, obviously, is that most of the appliances do cause some decrease in the overjet. So if there's going to be a decrease in the overjet, you're more likely to become a class 3, and you should warn a patient of that potential the closer they are to edge to begin with.
Yeah.
But
Agreed. Yeah.
Other than that, we really don't understand the risk factors that would make it more likely.
Good.
Right. So all of that stuff holds. But what Barry is saying, I think it's a very important contribution to the answer, is basically you look at where they are. And sometimes these changes that I just described that happen, likely to happen to some degree, will be actually a contribution to their bite, will make it better, and actually a positive change. And other times it's a concern, because they're already biting edge to edge. And so now you're going to very quickly turn them into a little bit more of a class 3 bite, because they're already biting edge to edge, if it happens with them, right? So this is what Barry's saying, that take into consideration their starting point and the implications of those bite changes, if they take place. You should make the patient aware of that, so that they don't freak out when it happens afterwards.
Okay, one more question sent in by chat. It's my understanding that CPAP can also change a bite. Do you agree?
Absolutely. I mean,
Okay.
Alan Lowe got sick and tired of all of the pointing at oral appliances. So he actually did a study and published it showing, the mid-face, gets pushed in. He did all of the nasion, he did all of the orthodontic type of measurements on the Ceph, and demonstrated a statistically significant bite changes in tooth movement and actual orthodontic positions, like the nasion, these things actually shifting, actually changing facial profile. Nothing that the patient would notice, but something that was statistically significant and measurable.
Good, thank you. I see no more written questions. We're happy to entertain any oral ones. I don't want to point any fingers, but I know people who always ask questions. Dr. Jones, are you still with us?
Hey, Lawrence.
Hello, John. Hello, Barry. David. Yes, I have a question. Can you hear me?
I certainly can, loud and clear. We got a good connection tonight, Laurie.
Good.
In many ways.
I'm off topic, but very much appreciate what has transpired. One of the things that interests me is the reliance on AHI for the determination of success. John very pointedly pointed out how the numbers don't necessarily sync. And that's been a really good contribution. John Remmers talks about what he calls loop gain and O2 desaturation. Is O2 saturation in the minds of you folk a valuable way to determine whether a patient is in need of having a sleep appliance?
You mean if there's O2 desat, ODI?
Yeah, ODI. Is using ODI a useful tool?
Oh, absolutely. Yeah. I mean, the ODI is a measure of severity of the level of apnea. So maybe I'm not understanding what you're asking.
Well, what I'm saying is if ODI is a reasonable tool, it is a good tool as a screen, because getting somebody in a sleep lab in my area is a year wait, and maybe even longer because of COVID and what's going on. And so if you have some record of O2 desaturation, ODI, then maybe you can move the problem along instead of them waiting for a year.
Laurie, you're in Ontario?
Yeah, in Guelph.
In Guelph, right? So, I mean, I don't know that the RCDSO wants us doing oximetry as a general screening tool. I'm just saying it's our college, right? That's not something that they would, I don't know that they would be supportive of that. What you're saying is nothing wrong with it. I mean, I think it would be great to check the oximetry, have that bit of information that you can add to your letter that you send off to the physician. But you just need to know that the RCDSO right now, is not really clear on that. They probably don't even know what ODI means. Right. So, you just have to be careful.
You're so cynical, Dr. Viviano. So cynical.
Well, it is what it is,
So we have Dr. Sharon, if she's still with us, as I think the only physician. Dr. Sharon, are you still with us?
Yes.
So just to preface what Dr. Jones talks about, we all see medical shows and we all see the finger clip and we see the nurses going, oh my God, it's going down. Just the way I talk to patients is, look at, it's a meter of how much oxygen's getting to your blood cells. So, and for a lot of us who struggle, I'm in London where a PSG wait time can be 12 months. Can you speak to us in terms of, forget the rules and the colleges, because we all have to fight that battle, but is that not just a really good indication of how well your heart and lungs work? The amount of gas in the tank with a very cheap finger oximeter. Is that a good, fair assessment?
Yeah, so I would say, I'm always wary of taking any parameter in isolation, right? Be it AHI, be it oxygen saturation. And again, going back to John's talk, it really is the whole clinical picture, right? So you can have a patient, for example, who has an oxygen saturation, right, that can be in the moderate being about 85%, but they have mild sleep apnea, no sleep apnea, or that was just a brief desat, right, for about 10 seconds. You may see some reports saying, oh my goodness, desaturation, you need treatment. Whereas it may not be, because you have to look at the whole clinical picture. That patient is doing fine, they're otherwise healthy, no negative indicators on terms of quality of life, they're not fatigued, they're not tired. very mild AHI, and a few blips of oxygen desats. So all that patient does not need any form of treatment, right? You can have another patient who has extremely severe sleep apnea and their O2 sats are mild. Would you say that you're not going to treat that patient because they have very mild, and in some cases they have no oxygen desaturation, but we still see severe sleep apnea? So my take home, or what I would say, is that it should never be taken in isolation. If you are concerned, if you have done, you have a pulse ox on a patient and you are concerned about the number, start with a screening, be it the stop bang questionnaire, to see if that number is an indication of something else that's going on first. And based on that, decide if you want to have further investigations, but don't take the number in isolation.
Does that help, Lori?
Perfect. Thank you.
No problem.
And I think, I'm sorry, I think that's probably hits the nail on the head as to why it's a problem. For what they don't want is dentists to start using oximetry as the screening tool and hang their hat on that, even without taking everything else into consideration.
Mhm.
So as a tool, along with other screening that you do, and if you're using it thoughtfully that way, in a thoughtful manner, I think that you would be okay even with the college. But you're still testing the waters with them, right?
Cool.
I'm always very careful about making sure I don't give people the advice or recommendations to do something that'll get them in trouble with our college, right? Because I can't live with that, right?
No.
I know I didn't really follow up with the question, the last part of the question. I use it. Maybe you've heard of Circle.
Yes.
And I use Circle and I get 15 days of data, and then I use it and send it to the family's physician and say, I'm suspicious about that. Please write a script, because so many times I ask the physician and he says the patient doesn't need it. But if I give him data points, 15 data points, then it becomes a different issue. It's all about leverage today if you want to do the best for your patients, because you have to live in a system that inhibits any creativity. I didn't want to use it to be able to diagnose sleep apnea on my own. I want to use it to either send it to a sleep physician who does home studies, and he justifies it. It's just the system is impeding our ability to be the best that we can be.
Yeah,
And
I
so
agree.
that's what the question is.
And Larry, two things. First of all, I think that device is particularly good, so easy to use, and be able to provide, several nights data, a week's data, 15 nights data, whatever. It helps to deal with the night-to-night variability, as opposed to just sending somebody home with an oximeter one night and then thinking you've discovered something and sending that to the physician. So I think what you're doing is great. Personally, I'm saying, I'm acknowledging that. I think that's a great protocol.
Thanks, Laurie. I know I can always count on you for a very provocative question or two.
I'm just what you call a pain in the ass to you. That's what you mean.
No, you're not at all. Dr. Goldstein, I have my shirt on. Did you wear your? I think you wore your shirt tonight.
Absolutely. I was prepared this time.
Wonderful. What comments do you have or questions? Anything?
No, nothing. I think you're very great presentation.
Well, I didn't do it. I just organized it. After mine floundering last time, I'll never do that again. Okay, folks, it's 9:02. I don't want to curtail this. Maybe while you think of your final questions, I'm going to turn it back over to Bianca, our Director of
Recording will be posted.
Yeah.
Sorry, David. I see Andrea have her hand up. I think she has a question.
Oh, really?
Yeah.
Yeah, I had I actually have a question for you, John, about oral appliance, or anybody else who can answer. So, I'm relatively new to this arena. So most of my patients are referred by my sleep doctors for CPAP failures. But recently I've gotten some patients who can wear CPAP, no problem. They have no compliance issues, but their symptoms haven't gone away, and they're wanting an oral appliance instead, hoping that that's going to help their symptoms. And I'm hesitant to even try, because, if CPAP, why isn't CPAP working for them if they can wear it? So what is your experience in those type of patients?
So
who are you asking, John? Okay.
I'm asking everybody, all of you guys. You guys all know more than I do.
So John's a speaker, so let him answer.
So the AHI with CPAP, they successfully managed that, but you're saying they have some subjective symptoms that are unresolved. In other words, they're still feeling tired, right?
That's right.
They're still feeling tired.
Yeah.
Okay. And so, I mean, that of course can happen. Now, it could be because there's another reason for it that the sleep specialist has to take a look in there. I don't find them particularly good at going that extra step to try and determine whether it's a vitamin D deficiency or whatever else might be causing the issues.
Yeah.
You know,
yeah.
so that's an outstanding thing often. But the point is that you could make an appliance and do equally well with regards to resolving their sleep apnea and have exactly the same outcome. Or it could go another way and they could actually feel much more rested because there's something about wearing CPAP that's disturbing their sleep, right? So you won't know until, you know, after
But
it's done.
Do you find that you have, like, you know, some success with that? I
wouldn't hesitate. I wouldn't hesitate to try because
Okay.
there's a reason when people, you know, there's a reason the statistics are so high with regards to favoring oral appliances over CPAP. Patients find them more comfortable, more convenient, easier. There's less anxiety, all sorts of things. Now, you know, you don't know which one of those issues might be that's actually interfering with that person getting that restful sleep, even though the apnea is all gone, right? So unless you make the appliance and move forward, right, with the understanding that it may or may not, but we can try, and it's definitely something that would be an expectation you would have, right? But you can't guarantee it.
I never guarantee anything, so.
Right.
Except to be an excellent doctor and be compassionate and empathetic and try to help your patients as best you can. That you can guarantee, Andrea, and you'll do it.
So Andrea, could I add to that?
Absolutely.
So I do have patients who have CPAP and either one, you know, the AHI is fine and they're still fatigued, or they're having issues when they're using the CPAP. They feel like they have this choking that's happening when they're using it. And what we find sometimes when we do sleep endoscopy is that some of those patients have what we call a floppy epiglottis, right? It's a trapdoor collapse. So the pressure, the positive pressure of the CPAP is actually sometimes pushing down the epiglottis, which is going against what should be happening. So in some of those cases, if it fully closes it down, a patient may say that they just feel like they have this still a choking episode. They're still waking up, even though they're wearing the CPAP, and that's because the epiglottis is just snapped shut, and then it has to suddenly open again. Right? Or basically the CPAP has pushed the epiglottis down, not fully, but enough where, yes, the AHI looks good, but they're still not getting the amount of airflow that they need to get the subjective outcome of feeling rested. Right? So what we do during sleep endoscopy is, again, if we see that happening, we do the jaw thrust maneuver to see if, you know, because the base of the tongue is ultimately connected via ligaments to the epiglottis, by advancing the jaw forward to see if that would be enough to get enough tension to open up the epiglottis. And a lot of cases, that's all they need. So for those patients, it's either a discussion about, changing. So switching from a CPAP to an oral appliance, or in some cases, they need the combination. So you need the oral appliance to open up the airway, get that epiglottis, get some tension on the epiglottis, and then you could actually lower the pressures or the resistance of the CPAP to make it more tolerable for them.
Great. Actually, that patient, so I did make him an oral appliance. I actually just delivered it today. He is going to go get a DICE done in London, in Rodenburg.
Okay,
so,
yes.
I didn't know that that was available, like where else to send it.
Actually, I think Sharon, Andrea's in Richmond Hill, right? Markham, but you're in Richmond Hill?
I'm in Richmond Hill.
Yeah, so you guys are fairly close.
That'd be great. Like I'm very excited to.
Yes, we would have to share contact information.
For sure. Yeah. So in when you do DICE, like if you were doing it with a dentist, are you able to titrate appliances while you're doing DICE?
It's possible. It is possible. It's not done here right now. I'd love to have that collaboration done, but in the States, in Europe, you can have either the dentist or dental assistant come in and while the patient's asleep, be it supine in a different position, titrate to see, because sometimes, you know, you can titrate and then you over titrate, right? Where then the glosses, everything starts collapsing in. So it's good to see what's that sweet spot for that patient, right? But it's not something that I've done here in my fellowship. It was done, but I'd love to do it here as well.
Right, right.
Yeah, I totally be into that. I would totally be interested in if you need help on that.
Definitely welcome. Definitely. That'd be great.
Any other oral questions? I see no written ones. Does anyone else have something they'd want to ask John? And as it turns out, we have Dr. Sharon Morong with us as well. I said this can go on as long as it needs to, so it's not about the hockey game's probably over, guys. The Leafs have probably lost anyway, so let me scour about. Anybody have another question? Going once, going twice.
Just one question.
Oh, I see.
Okay, there. It's always the last.
So, John, to do with compliance with all appliances, have they done any to do with specific appliances? You know, or is it just a generalized all appliance?
Well, I mean, studies have been done measuring compliance, and it would be with whatever appliance was used in that particular study. But no, there's never been studies done comparing different types of appliances to see which demonstrated a higher level of compliance to speak of.
John, can you speak to DentiTrack? Are you up to date on their research?
Well, I mean, the thing with DentiTrack, I mean, it's a great product that's been around a long time. Of course, there's a cost associated with using it and the cumbersomeness of using it and stuff, and the physicians don't care. So
because they don't work anyways.
If the physicians don't care that you're giving them that additional information, it's never going to happen. It's not going to happen. When I asked a physician about this physician has since then retired. But when I asked a physician about this, he said, "Listen, as long as the Ministry of Transportation Communication doesn't care, you know, in other words, the people that say you can drive or not drive, they're not going to take it. They don't care, right? So, these things have to be mandated from." Legislation down type thing, right? So you could go through the effort of using the DentiTrack and reporting on it and so forth, and it's just another layer of complication and sophistication and expense that you have to pass on to the patient. And in the end, if the physician doesn't care and doesn't really take the information seriously, what's the point? You know what I mean? So that's where we stand with it. I mean, it's great. It's a great tool, a great device. There's even other type of compliance devices from Europe that have not really, done much in North America, because if the physicians don't care, why are the dentists going to be using this and adding that extra sophistication to what they have to do?
Okay.
And expense.
Thank you. Scott, you have a question.
Yeah, I'm coming from this at a slightly different angle. As John knows, we focus on the marketing for sleep dentists and doctors in the USA and Canada, and clearly affordability is a very major factor. So from a marketing standpoint, do you think it's also important to mention the fact that the overall maintenance costs for CPAP in money, in time and energy should also be considered? I mean, for example, John mentioned that, a CPAP user might go through 4 or 5 masks before he finds something that may or may not work. And I mean, that alone is $500.
Right.
It's not clear to me, Scott, whether when they're doing a trial like that, whether they basically are using loaner masks that are then disinfected and but it's not clear. I don't know, and that may depend on the people, right? And on the CPAP factory, if you will, right? So but it's not really clear. I think that some people will be paying for it, and for other people it's a certain set fee, and you get to try things out, and we're going to be finding what works best for you. Right.
Gotcha.
So
thank you.
Okay, thank you, Scott. John, I want to take you back to the comment I think I heard you say the physician said about DentiTrack. If MTO doesn't care, are you suggesting the MTO does, Ministry of Transportation, that looks after truck drivers, do they not even give any credence to oral appliances? Do they only want to see CPAP results? Or do they just not care how the
No,
appliance works.
the physician, I'm just saying this particular physician, when I had the conversation with him,
Right.
basically said unless MTO mandates it,
Okay.
right, that, you know, then, you know, it doesn't matter to me.
But MTO would reinstate a driver who was treated successfully on an oral appliance.
Right, based on the
Okay.
dentist that is prescribing it,
Right.
or not prescribing, delivering it, stating that the patient's wearing it, and so they'll do it in that without any verification that they're wearing it,
Right.
right? Other than your letter, right?
Right. Because as we know in the States, a lot of the rest centers have sleep inspection stations, and drivers live in fear of being pulled over and not having their documents, mostly CPAP.
Right,
It's not that way in Canada, of course.
right.
And now the only people across the border are truck drivers, so it's an ongoing story. I don't see any more written. A couple of really good comments. Thank you, John, for an excellent presentation. Thank you, John, and Go Leafs Go. Thanks, John. Very interesting. I've learned a lot tonight. So a lot of good feedback. It is almost 9:20. So folks, thank you so much for your attendance. This has been an excellent meeting. It's just under 2 hours. It'll be in 2 parts on YouTube by the weekend. And you'll also get John's lecture in PDF form through the Academy from me. And as always, reach out. If you have any questions, you have any suggestions, we're only as good as you make us to be. So we'll see you in 2 weeks on the 27th. I believe the start time is 8 o'clock because some of our speakers live 3 time zones away. We had a speaker from Las Vegas who couldn't get on until he got out of work. So I think it's 8 o'clock, but you'll see the notes and don't forget to register. So thanks very much. I will call the meeting to an end. And as I often do, using the closing of an old TV show. Good night, boy. Night, John boy. Would you kids go to bed? Night, folks. Thanks so much.
Good night, everyone. Thank you for
Bye.
attending.
Thank you,
John.
John. Thank you.
Bye now.